So we're now launching, we talked about how bad smoking is and who the smokers are. The next 4 sessions are going to talk about how to help smokers quit. And this is sort of a lead into that. So let's go to the next slide. So one of the things that happens is that when smokers go to doctors' offices, often the next action step doesn't take place. So about 1/5 of smokers never talk about it with their doctors. Only about 1/5 who talk about it get any teaching about it. Only 44% get any kind of medication, and over half feel guilty when talking about their smoking. So this gets back to the stigma. It means we really have to encourage, when we send our patients to the doctor, our smoking patients, our smoking residents, make sure that they're comfortable raising the issue and check back with them to see if the issue was even discussed. Next, please. So why don't physicians do a better job at helping patients quit? Well, this is a Schroeder list. Others might want to add, Frank might want to add others, but here's my list. They're too busy. You all know about primary care physicians being hamsters on a treadmill, and it's true, they feel very busy. The other thing is most of them were not well trained to help smokers quit. There's no financial bonus to doing that, although I must say I don't find this a very compelling argument, because there's no financial bonus to measuring blood pressure or checking weight, and yet those should be a part of what doctors do. Often they're not aware of available treatments and/or coverage. One other thing that's true for any way to change a patient's personal behavior is that it's kind of demoralizing, whether you're trying to get people to exercise more or to lose weight or to drink less if they're a problem drinker, or when they're using opioids or when they're smoking, is that most smokers can't or won't quit. And in fact, the cold turkey rate of quitting smoking is only about 4%. So unassisted smoking is very unsuccessful. A 6th reason is stigma. Believe it or not, only 1% of physicians smoke. And so there's liable to be an unconscious judgment when they see a patient who's a smoker. Tut, tut, you made a bad choice. Usually they're sufficiently diplomatic that they won't say that, but they may feel somehow that the patient isn't as deserving. A 7th issue is respect for privacy. Some sense that in this libertarian country, people have the right to smoke. And then the 8th is, if I get a dedicated smoker, try to urge them to quit smoking, they might say, I don't want to go to Dr. Schroeder, or I want to see Frank Vitale, because they're telling me things that I don't want to hear. In fact, the data show that even smokers with no intention of quit expect clinicians to help them quit, and worry that if they don't do that, they might not help them screen for colon cancer or breast cancer. I smoke myself, as I mentioned. That's a very rare phenomenon for physicians, a little more common for other health professionals, but still even nurses who used to have a very high rate are down to about 10%. And now there's a problem with the electronic medical record system with problems in identifying smoking. So these are all the reasons for not helping patients quit. Next slide, please. These are my responses for what a clinician should do to a patient who smokes. I don't have time, not acceptable. But there are 3 acceptable answers. One is to refer to a telephone quit line, and that will be a subject to a subsequent webinar series on our ECHO series. 2, establish systems in your office or hospital, and places like Kaiser or the VA do this very well. And finally, become an expert yourself. Next, please. So tobacco dependence is a 2-part problem. It's physiologic and it's behavioral. Next. And next. So, and next. So the behavioral, the physiologic aspect we talked about, the addiction to the nicotine, and treatment of that has to address this and combat the withdrawal that smokers get when they stop smoking. Now, I'll have to mention here that about 1/4 of all smokers don't smoke every day. So they may not be as addicted to the nicotine. They may be over on the right-hand side of this slide, which is they do it as a behavioral reason. But if you're addicted to the nicotine, and daily smokers mostly are, then you need medications for cessation, and we're going to cover that in a subsequent session also. On the right-hand side, you can see that the habit of using tobacco, the getting the cigarette out of the pack, the lighting it, the handling it, the smell of it, the smoke of it, is itself creating cues which reinforce smoking. So the treatment needs to address both aspects of this, the addiction, the physiology, and the personal behavior that drives smoking. Next. So does it help to intervene? Well, 1.0, I think there must be one other aspect to the slide. Next, please. Oh, back to the previous one. So the bottom isn't, there should be text, but I will tell you what it is. 1.0 is the odds ratio of just essentially if you don't get anything. If you hand out a brochure, your odds of quitting only goes up to 1.1, and the confidence interval there shows that it doesn't make any difference. So if you're well-intended and give a brochure, that's nice to do, but it doesn't help smokers quit. If you're a non-physician clinician and you urge someone to quit smoking, then the chances are increased significantly. So you have a 1.7 or a 70% increase, and 2.2 is what a physician creates. So you double, I shouldn't have said 70% was 1.7, but you increase it almost double. If you're a physician, you can increase the odds by 2.2, so more than double the chance of quitting. Next, please. So here are the famous 5 A's. They're simple. Ask about tobacco use, and every clinician is supposed to do all of these. Advise tobacco users to quit. Assess whether they're willing to make a quit attempt now or in the future. Assist with helping them quit, and arrange the follow-up care. So those are the 5 A's. Ask, advise, assess, assist, and arrange. Next, please. But what happens? Physicians, as I mentioned, undertreat smokers. So there was a medical center. This is the AAMC, is the Association of Medical Schools, and they surveyed over 3,000 physicians representing family medicine, general internal medicine, OBGYN, and psychiatry. And these are the frontline physicians for most smokers. As I mentioned, only 1% were current smokers. They did a really good job asking about whether the patient smoked. They did a really good job advising to quit. And then there was a huge fallout. So only 31%, less than a third, recommended nicotine replacement therapy. Only 17% arranged for follow-up, and only 7% referred to a telephone quit line. Next, please. So what are the challenges with performing those 5 A's? Well, in the ask, most physicians do ask. Most smokers answer truthfully, with one exception. Pregnant women mostly know that it's bad to smoke, and those pregnant women who are unable to quit smoking often feel so guilty about it that they lie when asked if they smoke. And that's why it's useful to use a carbon monoxide breathalyzer, which detects exhaled carbon monoxide, which goes up when you smoke. Advise, most clinicians do advise. The assessment takes a lot more time. You have to find out, are they ready to quit? Have they tried to quit before? Which drugs did they use? How they feel about their drugs? Does the person that they live with smoke? What do they do about ashtrays? And all of that. And it takes time, and busy clinicians sometimes punt on that. The assisting takes even longer because you've got to lay out, these are the 7 medications, these are how they work, these are the pluses and minuses of using them. And the arrange component, which is to do the follow-up, just often the ball gets dropped. So an acceptable alternative to the 5 A's is the shortcut, and there are 2 versions. One is ask, advise, refer, often to a telephone quit line or to a system in your in your place where you practice, or ask, advise, and directly connect to a telephone quit line or to some other place. Next. So you're going to hear in the next several sessions, echo sessions, how telephone quit lines work. And this is something that I think really fits to our population, the handoff to the quit line. Counseling and motivational interviewing, how those work, and pharmacotherapy. And I'll leave you with a couple of other statistics. One is it takes probably from 10 to 30 attempts. Let me repeat that. 10 to 30 attempts before a committed smoker is actually able to quit. So if they try and fail, don't be discouraged. Keep trying. And I'll end with a good news statement. There are now in the United States more ex-smokers than current smokers. So the message is keep trying. Thank you. It's been a pleasure talking with you, and we'll move on to other speakers in the subsequent echo sessions.
Steve, thank you so very much. Let's see. Waiting for there we go. All right, so I'm gonna take a moment and look in the chat box and see if we have any questions. Chat box would show up for me, I'm telling you. All right, here we go. And thank you to everybody who put their information in, who joined us. All right, do we have any questions? It sounds like somebody might have had something. No, okay. Well, in that case, Celine, I got your message. Are you okay if I ask this right now?
Yes, that's fine. Okay,
great. So Celine wrote me that she has a question regarding feedback she received in helping a client look into NRTs with her provider. She was told that some NRTs can have negative side effects on mental health conditions like anxiety, and therefore NRTs maybe should not be are not recommended for people with certain mental health diagnoses. Steve, could you speak to that a little bit?
There's a lot of confusion about this, and let me explain. When addicted smokers stop smoking, they do in fact feel more anxious. And a lot of people think, oh my gosh, you know, their mental health condition's gotten worse. Probably the reason they're anxious is they don't get the nicotine that they're used to. So giving the nicotine replacement therapy actually is a treatment for the anxiety that is a component of the withdrawal. I hope that's clear.
That's great. And you know, Celine, if I can connect the providers with anybody, just send me a note and I'm happy to get them more information or connect them to a resource.
Okay, thank you.
Thank you. And then there's
was that helpful, Celine?
Yes, because the client decided to opt out of the NRTs after meeting with the provider, and I haven't been able to follow up with her since that visit because I wasn't actually in the appointment with her. So I want to kind of see how things are going with the information and the support that she did get for how to quit. And then if it seems like, you know, things aren't working out, I feel like I'd like for her to have more information about, you know, options for NRTs if she feels like she still needs it and maybe is concerned about how that might impact her anxiety.
So the other thing I would suggest is if she's worried about the NRT, the oral medications are also a good option. Ideally, you combine them with MRT, but if, you know, each of these smokers has his or her own story. So you need to be very individualized and tailor it to where they are.
Yeah, okay.
Right. And then
Celine, this is Frank. NRT stands for nicotine replacement therapy. So all they're getting is nicotine in a different form. They already had nicotine in their body from smoking. We're eliminating all the other chemicals, all the dangerous chemicals that they're getting by going on NRT. So there is no negative reaction from using any kind of nicotine replacement because it's just nicotine and they already have it in their body. We're just giving it to them in a different form so that they can slowly taper down. And Dr. Schroeder is absolutely right. What they're feeling is withdrawal symptoms. So the nicotine replacement will lessen that or get rid of it completely.
Okay. Is there any literature or anything that you would recommend that I could review with the client or with the provider to just kind of get a fuller picture of what you're talking about?
Oh, there's a million things, but let me think. I can't think of anything specific right off the top of my head, but we'll find
Okay.
something for you.
Okay, thank you.
That's great. Thank you. And I can facilitate that information if you need me
Thank
to.
you.
Yeah, thank you. And then we got another question. For the expanded ask question for pregnant women, the multiple choice question, does that actually help them answer honestly?
It's a good question, and I don't mean to say that every pregnant woman lies about her smoking, because most of them are forthcoming. But if you have a suspicion, if you smell it on their breath or their clothes, or you just have a reason, you might want to ask a second time and say, do it with an empathic. It's really hard for pregnant smokers to come clean with it. I've had some patients who've done that, but it's really important to talk about it. Can we revisit that question? Or if you still have a suggestion, if you have a CO breathalyzer, have them breathe into that. And if it's more than 10 parts per million, then it's likely that they're a smoker.
That's
The
great.
other thing you can do is just generally, if you're working with pregnant women, ask the question, when did you smoke your last cigarette? Because if they've never been a smoker, they're very simply consider I've never smoked. But it's kind of a way to a different way of getting them to answer truthfully. I noticed I went for my yearly physical 2 months ago, and that's how the doctor asked me that question, rather than do you smoke or do you not smoke?
Great. Thank you. Any more questions about the topic at hand today?
Becky, this is Linda Bailey. I just wanted to add in that on the issue of pregnant women, we see many pregnant women who smoke spontaneously just quit smoking during their pregnancy. It just becomes something they don't like the taste of or the smell of anymore, and actually find that the postnatal period is really important, especially those first 8 weeks after the birth of their child. It's really important to make sure if they have quit that they don't go back to smoking. And so just something for folks who work with pregnant women to keep in mind, that it's not only the pregnancy that you have to worry about. Even if a woman is successful in quitting during the pregnancy, it's sort of the, as the child is born and is a little infant, that you have to worry about them going back.